we're going to continue and discuss treatment planning in orthodontics. So when we do treatment planning, we should set up at the beginning what are the aims of the treatment. So the first one will be the facial or the aesthetic component, which is positioning of the dentition within the skeletal on soft tissue environment for optimal facial and dental aesthetic. The second will, which is the occlusal aims, which achieve a stable and ideal aesthetic and functional occlusion. And the last one, to maintain the periodontal health and not to cause any harm for the patient. So how to plan achieve the facial aims of the treatment? We should plan the treatment around the face. Treatment planning should begin with the consideration of the upper incisor position and whether this one need to be changed or not. So where the upper incisor should be. Now this table came from the handbook textbook, and it say the labial surface of the upper incisor should be parallel to the true vertical line and adequately support the upper lip. And we're going to come this into details, discuss this one. That's the AB position of the upper incisors. Then the vertical position, it should be around 3 to 4 millimeter of the upper incisor should be displayed at rest. That's the incisor show at rest. Curvature, which is we call it the smile arc, should be parallel to the lower lip, and the center line should be coincident. These are the transverse relationship. So we're going to explain all of this now. So first one is the AB position of the upper incisors. So this is a nice study done in Lebanon by Galib et al. And what they did is they changed the inclination of the teeth. They took several photographs and they manipulated the inclination of the teeth. They started with the proclined one and retroclined one. And what they found is that the patient preferred when the upper incisors are 90 degrees or 93 degrees to the horizontal plane, which is similar to the table mentioned in a handbook textbook, that this incisor should be parallel to the vertical line. They should be upright. And patients, they don't like it when, for example, it's a 15 degrees inclination. And this is very important. This is not the AB position. This is not the support of the lips. This is about the inclination of the teeth. So if you see a patient like this with a proclined upper incisors, all what you need to do is to retrocline, just to torque these upper incisors to get them at the right angle. And as you can see here, all what we did here is just to uprighten these incisors, changing the angle of the upper incisors. However, this is dangerous and it's not always possible without causing a problem with the bone. So if you look here at the lateral cave that we took just before we do the bond-up, we have a very thin rim of bone remaining around the central incisors. We have a plenty of bone here. Patient declined the extraction decision. However, sometimes you just need to do extraction because you want to retract this upper incisors posteriorly a little bit and then give a place to do the torque. Because if you do torquing the incisors, as we can see here, what you need to do is to retract this upper incisors, move this root labially, and what you're afraid of that you will end up perforating this palatal plate of bone. So what you need to do is to do extraction, get the crown back a little bit, and then move the root forward to give it a correct torque. So this is about the inclination of the teeth, which is the first point about the vertical anteroposterior relationship. The second one is the AB position of the upper incisors, where the upper incisors should be in the AB position. Now Andrews, when he proposed, he said that if you draw a line perpendicular through a vertical line from nasien, the upper incisors should be sitting on this line. So you have to try, if they are behind this line, you should move them forward, and if anterior to this line, you have to move them posteriorly. However, our thinking has a little bit changed since then, and that's what is mentioned in the handbook textbook in the table when they said enough support to the soft tissue. And this is paragraph quoted from Prophet textbook. And we said is when the prominence of the incisors create excessive lip separation at rest, so that the patient must strain to bring the lips together, the teeth are too protrusive, and retracting the incisors improve the facial profile. So what do we mean? So if you look at the paragraph here, you can see that's again from Prophet textbook. These incisors are protruded to the point that these lips are stretched and they are separated from each other. All what you need to do in this case is just to move these incisors posteriorly, so when the patient bring the two lips together, they meet easily. So that will improve the patient's profile. So meaning, when you do treatment planning, you don't want to push upper incisors to the point where they cause this kind of separation. On the other hand, we don't want to over retract the upper incisors to the point that these lips will be under supportive. However, to decide this, you don't have to look at the AB position of the incisors using the lateral cuff, because the support of the soft tissue depends also on the type of the soft tissue. So for example, if you look at this patient here, the lips are thin, while this patient here, the lips are thick. So if we look at this patient here, even if the upper incisors are on the line that is decided by Andrews, that is in the vertical line, still these lips are thin, they look under supported. We need to support these lips by moving the upper incisors forward. While on the other hand, if you see this patient here, she has a thick lips, which means whether we procline the upper incisors forward a little bit more than the line proposed by Andrews, or we retract the upper incisors, the effect on the upper lips will be minimal because this patient has a thick soft tissue. Or even if we examine this patient and we found the upper incisors are protruded, still the patient is happy with the way the lips are because these lips are thick. So you can determine the aesthetic limit of expansion from tooth-bone relationship on the lateral cuff as it was proposed by Andrews. You need to evaluate how much these teeth are supportive of the soft tissue, and is the soft tissue thick or thin, and do we need to retract them or to procline them. To help you to understand this point even more, this is the same patient that we saw here, and this is her malocclusion. She was treated by extraction of 2 premolars and retraction of the incisors. So these incisors now are retroclined, but this one and these laterals, they are supportive of the lips. We did extraction, we did retraction, and this is here how she looked after the treatment was done. She lost weight definitely, but as you can see, even though the incisors are retracted massively, she was treated with extraction in the upper, reinforcement of anchorage with headgear, a lot of retraction of the incisors. Soft tissue is barely affected. So why is that? Because the soft tissue here is thick, they can take it. And the patient, a little bit of protrusion of the incisor is good, or the lips, it's good in this case. And also, it's complicated. It's not only about the AB position of the incisors alone, it's about the lips, as we mentioned before, and the nose, as you can see here. So for example, if you're gonna treat this patient, even if these incisors are here, my treatment should be to push the incisors forward, give it a little bit of support to reduce this nasolabial angle. When the patient has a protrusive chin, as we can see here, you want to do anything but retraction of the lower incisors. Because if you do retraction of this lower incisors, this lower lip will be dumped even more when compared to this chin. So when you do treatment planning and decide the AB position of the upper incisors, you need first to look to the inclination of the teeth. Teeth should be parallel to the vertical line that is drawn for nasal. It's just parallel the angle. Now regarding the AB position, we start with where the incisor in the AB position relation to the end perpendicular. But then, and the most important one, to see how much these teeth are affecting the soft tissue. Are they causing protrusion of and separation of the lips or not? If this is the case, then extraction treatment should be done. And if non-extraction treatment will result in this, meaning that there is no protrusion, but if we procline the incisors, we anticipated that this will result in a protrusion of the lip and separation between them, then we should not consider a non-extraction treatment, and we should consider extraction to avoid this from happening. So this is how we should decide the ideal position, AB position of the upper incisors. So now we are done with the AB position of the incisors. We move to the vertical position of the incisors. So this is photo taken from Prophet as well. As you can see, during rest, the upper incisor the patient should show 3 to 4 millimeter of the upper incisors, while during smiling, it should show the full clinical crown plus 1 to 2 millimeter of the gingiva. If the patient is showing less than that, as you can see, that will kind of give the patient an older appearance. So when you do the treatment planning, you should aim for a little bit of extrusion of these incisors to achieve a proper smile incisor show and smiling. However, when we do this planning, if the patient has a more of a gummy smile when she's smiling, more than 1 to 2 millimeter, there we should try to plan and intrude these incisors to improve the incisor show in smiling. However, when we do this, we need to know the etiology of the increased incisor show in smiling. Meaning, so this patient here has a gummy smile. She has more than 1 to 2 millimeter of gum showing during smiling. But then when we do that, we have to examine what is the amount of the incisor show at rest. So here in this patient, the amount of the incisor show at rest is increased, which means the cause of this problem, either the lips is short, the upper lip is short, or we have vertical maxillary excess, the maxilla is grown vertically, or the upper incisors are extruded. But if we don't have increased incisor show at rest, when the patient at rest is normal, that means that the cause of this problem is either hyperactive upper lip, which means that when the patient smiles, the muscles surrounding this oral cavity is hyperactive to the point that will pull everything up, or the clinically crown are short. So when we do our treatment planning, we need to first know if the patient has a gummy smile or not, then identify the etiology for this problem, because that management is different. And for example, if you look at this gummy smile, say, okay, I'm going to do an intrusion for these upper incisors, and the etiology was hyperactive upper lip, and the patient during rest is show normal incisors. So when you do intrusion, the gummy smile will improve, but the patient will show no teeth during rest, which give her an older appearance. So when you do the diagnosis, you should measure for example, in this case, when you see that the patient has a gummy smile, you would go immediately and check the amount of the incisor show at rest. If it's increased like we see here, that means it could be either gummy smile due to extruded incisors or vertical maxillary excess, or short upper lip. So you measure the upper lip, and the upper lip should be 21 to 22 millimeter. If you measure the lip and it's 21 to 22, then yeah, go ahead and do the intrusion of the incisors as we did in this case. So you intrude the incisors and you remove the gummy smile. So during rest now, the amount of the incisor show is normal. But remember, if the patient has a gummy smile that is severe enough to this point, or even a little bit less, the only method is to go for orthodontic surgery. Orthodontics can't help this patient. We need to do orthodontic surgery in which we do impaction for the maxilla. Just remember, and that's very important, that as the face grows, there is a tendency to show less upper incisors. So the lips will go down because the muscles become more relaxed, more flaccid. So the lips will go down and the patient will show less of the incisors. And remember that most of our patients that we treated are teenagers. So 10, 15, 20 years later, the lips will go down, covering more of the upper incisors. So always try to avoid over intrusion of the incisor during the treatment, not to make your patient look older earlier than their age. So after you consider the vertical position of the incisor and gummy smile, you need to look at the smile arc, which means that the smile of the upper teeth should follow the contour of the lower lip. So for example, here, as you can see in the top photograph, it's there, it's nice, but it's flat, as you can see. So all you need to do when you plan your treatment, just to extrude these incisors a little bit so you give it the curvature back. If you forgot to do that during bond-up, you can do that simply during the finishing step down bend, and it should be sorted out. So now we finished AB position of the incisors, vertical position of the incisors. We go to the transverse position of the incisors. We start with the midline. This is a famous picture of Tom Cruise. We know he's famous with the midline shift. So you need to look at the midline and then you decide where the teeth should be by moving. So for example, if you're doing treatment planning, we know that in the transverse dimension, these upper incisors have to move to the left side. This is a systematic review which looked at the tolerance of the people to the amount of on the smile analysis. So they found that a small dental midline deviation of up to 2.2 millimeter can be considered as acceptable by patients and by the orthodontist. However, inclination, if the midline angulation is more than 10 degrees, which is measured from the papilla of the between the two incisors and the incisor edge, that will be start to be noticed. However, 2 millimeter, that can be measured as a 2 millimeter of a distance. So you need to consider the midline and the inclination. However, when they evaluated the buccal corridor, the smile arc, and they found it does not really affect the attractiveness of the smile. However, another studies they found that smile arc is the most important factor in the smile analysis, even more important than midline and buccal corridor. That's again depending on the sample that is being picked. However, in this systematic review, it said that smile arc, buccal corridor, they're not really considered by the patient. Keep in mind that these studies are done in different population. Here, the case might be different, and patients might focus on this kind of like buccal corridor or the smile arc. Now, the last thing, when you consider the AB position of the upper incisors, that sometimes there is a limit of what we can do with the braces. So, for example, if you look at this patient, he's a class 2 division 2. He has a soft tissue. We agree for a fact that we need to give support for his upper lip. We don't have to retract these lips. So if you see that he's a patient in the alignment stage and he has a huge overjet, this overjet can be reduced by retraction of the upper incisor. First, patient has a soft, thin lip, increased nasolabial angle. The amount of retraction is huge. So if we do retraction of this incisors, what's going to happen with this lip? That it will be dumped back. So all what you need to do is, for example, moving the lower teeth forward. But this is very excessive, and this is a lot to be done with fixed appliance. First, you are violating the stability a lot and the lip space. Second, you might end up with a lot of gum recession. So what we need to do now is to refer the patient for surgery. So there is a limit for what we can do with our treatment. So one of the aims that you should decide as well, can we camouflage this patient? Or if he is a young patient, do we need to go for a phase of a functional and growth modification to use the growth that the patient has? So for example, if this patient was only 12 years old, we might give it a go with a functional appliance, trying to stimulate the growth or get benefit of the growth that is already there with the patient. For that reason, there is an envelope of discrepancy developed by a prophet. So if you look at the paragraph here, that represents the lower arch. The inner circle in black represents the tooth movement that we can do without with braces alone. While the outer circle is the red color that we can do with growth modification, whereas the bigger circle is with orthodontic surgery. So for example here, if the lower incisors are class 3 and you need to retract them, you can retract them up to 8 millimeter to get them back into the normal relationship. So now we are done with the aims of treatment, with the aims of positioning the teeth in the proper position. That is the soft tissue aim or the facial aesthetic aim of treatment. Now we move to the second one, which is putting the teeth in the ideal aesthetic and functional occlusion. So when we do the treatment, the aims of the treatment to achieve first the Andrews 6 keys of normal occlusion, which we all know. And then these are the functional occlusion, and these one were proposed by Roth, that you need to achieve canine guidance, which is better if you can then achieve group function guidance. There should be none, and there is no non-working side contact or interferences, and there should be an anterior guidance and reduced contact, extruded contact position and intercuspal position coincident. That means there is no displacement. Now, what we do is to try to achieve Andrews 6 keys of occlusion, doing a canine guidance, non-working side interference, and anterior guidance. That's thing that we try to do it in most of the cases. However, there's no evidence to support that we should do something like this, and definitely the patient should not have any displacement when he finish orthodontic treatment. Now we are done deciding the aims of the treatment, deciding the AB position, whether this pay of the incisors, vertical position of the incisor, transverse position of the incisors, whether this patient is camouflageable or not, whether we need functional appliance or not. Now we go to plan the anteroposterior position of the lower incisors and the lower arch at all. So remember that we said that we start planning by deciding where the upper incisor should be. But then we don't go and plan the upper arch, we go and plan the lower arch. And why is that? Look at this patient here. If the overjet is 5 millimeter and we decided to plan the upper arch, so we need space to reduce this overjet by moving these upper incisors posteriorly by 3 millimeter, which requires 6 millimeter of space in the arch. While if we decided to plan the lower arch first, because we build the upper arch on the lower arch, you start the plan and say, okay, this is a mild crowding, I'm going to go for a non-extraction treatment. So if you decided to go for a non-extraction treatment, that means that the lower incisor, for example, will be moved forward by 2 millimeter because we have a crowding of a 4 millimeter. That will reduce the overjet down from 5 into 3, which means now that the space requirement at the upper arch is just only 1 millimeter, 2 millimeter per two sides, 1 millimeter of retraction of the upper incisors. For that reason, we decide where is the incisor should be, we decide if the patient camouflageable or not, we decide if we need functional appliance or not, and then we go to the lower arch. Then when we plan the lower arch, we have to answer a very important question. Do we need to expand the lower arch to provide space for crowding, or do we need to extract teeth? That's a dilemma. However, and I quoted this one from Prophet again, in rational contemporary view, the majority of orthodontic patients can and should be treated without removal of teeth. So our treatment option at the beginning should be non-extraction. However, in a lot of cases, we need extraction, either to compensate for crowding, to relieve the crowding, or to correct the incisal protrusion and improve the facial aesthetic, or to camouflage the discrepancy between the two jaws. For example, patient with a class 2, you need to do extraction in the upper to retract the incisors to camouflage the class 2 skeletal relationship. I like this diagram in Prophet again. So when you decide regarding the whether to extract or expand, you need to look first for the aesthetic consideration. We mentioned in the previous lecture a lot about the determinantal effect of extraction and non-extraction, and we covered that already. However, when we do the planning now, we need to do first, if we're going to extract or not, the aesthetic consideration. So there's an area here in the middle where if you do extraction or non-extraction treatment, patient profile or stability will not be affected. However, the more we go into a non-extraction treatment, the fuller the lips are. The more we go to the extraction treatment, the flatter the lip will be. So how is that going to affect the treatment plan? So, for example, if the patient has already protrusive incisors, if I go for a non-extraction, that will give even more protrusion, fuller lip, so I have to try to avoid it. If the patient has a thin lips, I should try to avoid any extraction treatment because that will result in flattening of the lips. They are sensitive to this kind of tooth movement, in which I will move the incisors posteriorly. But there is again area here in the middle where either options are acceptable. What about stability? And we're going to cover this after aesthetic consideration. If we do an non-extraction treatment, that does not mean it's stable. What I said is less chances of relapse. All right. And if we do a non-extraction treatment, I have to repeat that. If we do a non-extraction treatment, that means that the results kind of less stable. But we can't say that the extraction treatment, and you go for extraction just because of stability, because we know that the stability and relapse are multifactorial. One of them is extraction, and we know for a fact excessive proclination of the lower incisor will not be stable. However, as we discussed as well in the extraction non-extraction lecture, we saw that even if you treat the patient with non-extraction and you do retention, the results will be the same as if you do an extraction with the same regime of retention. So these are some things you need to consider. So again, going back to the profile of the patient and the aesthetic. So if you go for an extraction treatment, you will give more support to the lip. If you go for extraction treatment, less support to the lip. When you do decide that, consider the thickness of the lip. The thinner the lip, the more they will be affected by this. Just remember this photo whenever you plan a case. You don't want to convert, if you're gonna go non-extraction treatment, you don't want to do this to the patient by excessively proclining the incisors. Or on the other hand, if you have a patient like this, you need to go for extraction to improve the separation between the upper lips. Now, stability consideration, we said about the aesthetic consideration about the extraction or expansion. Now, what about stability? Again, from where we covered, we know that extraction does not increase the stability. However, we have this diagram again from Prophet textbook, and again, it's from limited data. Limited data. That's not a strong evidence. What he found that if you procline the lower incisors by 2 millimeter, that will be stable. And if you expand the intercanine by 1 millimeter, that will be stable. But look here at the intermolar, you can expand by 3 millimeter and you should be fine. Why is that? First, let's look at the incisors. Why proclination only 2 millimeter? They said because of the lips. The lips have a smaller leeway compared to the buccal cheek. Once you procline them more than 2 millimeter, you will hit the muscles. The muscle will retract them. So don't try to procline them more than 2 millimeter. And regarding the intercanine, as you can see here, it's mostly 1 millimeter that you can do expansion. And the cause of that, because first, during age, the remodeling process, the intercanine will be reduced. So you can't increase it, and because it's going to reduce with time. Plus the pressure of the lips is limiting of how much we can expand the intercanine. So you don't limit the expansion into 1 millimeter. However, if I commit and I don't expand more than 1 millimeter, does that guarantee stability? The answer is no. According to the work that is done by Little, still relapse is inevitable. We know that the more expansion they do, the more relapse you get. But again, if you do proper retention, you should be fine. So you need to understand when you do proclination that if we do it more than 2 millimeter, then yes, I'm proclining the incisors into unstable position. Patient has to commit to a lifetime retention. But you don't procline these incisors without telling the patient about the relapse potential. And the same here in the posterior. The last thing to consider about expand or extract is the soft tissue. You don't want to procline too much or expand too much to the point that you kick the teeth outside the bone and causing dehiscence, fenestration, and even gum recession. This is again photo from textbook Prophet when they fixed this one by lateral positioning flap to cover the gum recession. So Prophet suggested a guideline for orthodontic extraction in a class 1 cases. So number 1, if the crowding is less than 4 millimeter, most of the cases we don't need extraction to be done. However, in some cases we still need extraction in which the patient has incisor protrusion and he is complaining. There is no crowding, but the patient is complaining by the amount of the protrusion of the incisors. Or a severe vertical discrepancy, for example, an anterior open bite. Sometimes we extract the sixes to reduce this amount of the overbite. And if the crowding, the arch length discrepancy is between 5 and 9 millimeter, and here is the one that is a borderline. Both treatment extraction and non-extraction is possible. However, the decision will depend on the amount of the support that the teeth give to the soft tissue. If the soft tissue is under supported, we go for a non-extraction option to move these upper incisors forward to give more support for the soft tissue, and the other way around, if we have an over or proclined upper incisors, we go for the extraction. So these are the borderline cases where extraction, non-extraction can take place. Well, if the arch length is more than 10 millimeter, then this is definitely an extraction treatment. And something to think about, that this extraction treatment will not affect the patient's profile. Because simply, if you have a 10 millimeter of crowding, that means 5 millimeter on each side. If you extract the premolar, that will give you 7 millimeter. So you need 5 millimeter of this space, so which is going to be occupied by the teeth and relieving crowding. 2 millimeter will be burned as an anchorage lost during this process. So the AB position of the upper incisors will not be affected. So extraction in the severe cases has limited effect on the patient's profile, and you can easily just go for the extraction to relieve crowding. And this is a nice table from Prophet as well, in which it tells you how much you gain from the space you gain by extraction of different teeth. So let's focus on the first molar. If you extract the first premolar, the amount of the space you get to relieve the incisor crowding is 5, while the second premolar is 3. So if you have a case in which you have a lot of crowding anteriorly, you go for the extraction of the first premolar and not the second premolar. While if you have a crowding more in the posterior arch, you go for the posterior tooth more, which is the second premolar. So as you can see here, if you do even want to do retraction, you get mostly 5 millimeter of the space, while in minimum cases, that's minimum you get 2 millimeter, while using the 5, the maximum you can get 3, and in some cases you get 0. That's the minimum you get because of the mesial migration of the sixes. So if you have a case in which you need most of the space for the anterior segment, don't ever go and extract the second premolar and go for the first premolar unless you have dental health issues related for the tooth, for example, caries or root canal treatment. Just keep in mind that these numbers came from studies in which they used just conventional anchorage management. They did not use DADs. Now, what about if a patient has dental protrusion and crowding? So if the patient has, that means that we need to retract. We can't afford to do non-extraction treatment because that will make the protrusion even worse. So for that reason, if you have a patient with a protrusion, aim should be extraction and retraction to achieve improvement of the patient profile. As a general rule, each millimeter of retraction will be followed by 2/3 of the distance by the lips. So basically, if we retract the upper lip by 3 millimeter, that means that the lip protrusion will improve by 2 millimeters. So the aim should be, if you have a patient with protrusion and crowding, is to do this retraction. However, when we say that if you retract the upper incisors by 3 millimeter, you get 2 millimeter of retraction of the lips, that's variable, and it's different from patient to patient, and it's different by the types of the soft tissue, again, if it's thick or soft or thin lips. Something as well to consider that when you do extraction and retraction of the lips, the reason why we get mostly 2 to 3 millimeter of retraction, because if the lips, they are incompetent, they are separated by the teeth, you do the extraction, you do the retraction, the lips now become retracted. At some point, the upper lip will touch the lower lip, and both of them, they hold each other and they stop retraction, even though the upper incisors and lower incisors are retracted. We're going to discuss that even more now in the next lecture, which is talking about, or the lecture after, talking about bimaxillary proclination. So just to summarize, think about how to manage regarding the extraction in the treatment. The more you can expand without the incisors moving forward, which means without invading the lip space and give less space, stable results. Moving the lower incisor forward mean more protrusion, and in some cases of a thin lip or already protrusive, it will be unacceptable aesthetically. So the more you expand from the molar area, the more you can do a treatment without extraction, a non-extraction treatment. The more you can close the extraction spaces without over-retraction of the incisors, meaning that allowing the posterior teeth to move forward whenever we want them to move forward, and avoiding excessive space and over-retraction, the more that we can do an extraction treatment, because this is our limitation of extraction and non-extraction. Here, if you do non-extraction treatment, you might excessively procline the lower incisors to unstable, unaesthetic position, and maybe jeopardizing the periodontium. While if you do expansion in the transverse dimension, it's kind of more stable and more doable. And the same if you want to do an extraction treatment, you need not to over-retract the upper incisors. For oral health, excessive expansion, as we said, it causes risk for gum recession. However, masticatory function is not affected by either extraction or non-extraction option of treatment. There is certain situation in which proclination, we said about proclination that is not stable if it's more than 2 millimeter. However, clinical situation where the incisors can be proclined more than 2 millimeter and still stable. The first one is a mild crowding. Second one is class 2 division 2 malocclusion. And the whole idea is that the upper incisors is in a full control with the lower incisors. It's not allowing any contact to happen with the lower lip. So that means this is not the most or neutral position of the lower incisor. they can move forward. The same thing if the lower incisors are retroclined by active lip or thumb sucking habit. Sometimes in the surgery we do a decompensation in which we take the compensation that took place. So if we have a retroclined incisors and patient want to go for surgery and he's class 3, we can procline these lower incisors and still it will be stable. So now we finished planning the lower arch, then we plan the upper arch in the same manner that we did with the lower arch. We look at the incisors position, AB position where they should be. We look then to the amount of crowding that we need to relieve, midline if we want to correct, smiling arc, our amount of the incisors that show at rest. We do everything related to the upper arch in the same manner that we discussed now about the lower arch, about the extraction and non-extraction or expansion. So then now we decided what we're going to do with the upper, we decided what we're going to do with the lower. We need to plan the to achieve the occlusal aim of the treatment and the tooth movement that's going to take place. So here we're going to give you an example how we should think when we hold the study models. So let's assume that we decided to do an extraction of upper 4s and lower upper 4 and lower 4 to relieve crowding. So the first thing you need to think, okay, I'm going to extract this 4. The amount of the crowding, let's assume in this case, is 3.5 millimeter. So I need to retract this inside. We start with the lower arch because we build the upper arch around the lower arch. So, and you start with the canine. It's always the corner. Canine, then molar. So the sequence, lower arch, canine molar, then upper arch, canine molar. So you look at the canine is a half unit class 2. When you need from this space, half of it. So you extract the 4, you retract this canine until you achieve the amount of retraction that is required to relieve crowding. So you retract the inside canine by about, for example, here in this case, 3 millimeter. And then you get from the extraction 7 millimeter. The rest of that will be by the movement of the lower molar. So we need to burn anchorage. So we are fine. We don't have to reinforce anchorage. So then now you need to move to the upper arch and say, okay, we did extraction here. I need to move this canine back in a class 1. Remember, when you do treatment planning, you have always to place your canine into class 1. Once you place the canine into class 1, overjet will be automatically corrected. Incisor relationship will be class 1 and you will not have any midline shift. So the canine is the key. So now we said that we retracted this canine posteriorly. So now we plan the upper canine. Now this canine moved back, which means that this canine now almost biting here, converting this canine from half unit class 2 into a full unit class 2. Now we extracted, we extracted this premolar, so we need to retract this canine 1 unit until it's back into a class 1, which means that I need all of this space, which means that I am not allowing my molar to move forward because the molar relationship here is a half unit class 2. This molar will move forward about 3 millimeter, converting this molar relationship into a class 1. We're going to do extraction in the upper arch and lower arch, so your final molar relationship on this buccal segment is class 1. So we can't afford to allow this molar to move any 1 millimeter forward. So we have to reinforce anchorage with absolute anchorage using TAD and retraction. So by doing this, we make our life more difficult. So imagine if we're going to do this again, but instead we're going to do a non-extraction treatment in the lower arch. You see that this canine is distally angulated and we have crowding. So once we do an alignment, this canine will move forward a little bit. So the canine relationship will be either half unit or even less. It will be quarter unit class 2 because this canine now is going to move forward. So now instead of this canine biting here, it will be biting here. So, it's a quarter unit class 2. So I'm going to go and do extraction. Which tooth should I extract when I need to move the canine back only a quarter unit? Oh no, it's not 4, it's 5. Your molar relationship is a half unit. If we decided to do a treatment in the upper arch only with extraction, the final molar relationship should be a full unit class 2, which means that I have to allow this molar to move forward from here until achieving class 2. As a rule of thumb, if your canine relationship half unit or more, after we do our calculation in the lower, you need to extract upper 4s. If it's less than that, you can go for the 5s. If you need more than 60% of your extraction space or 60% and more, you have to reinforce your anchorage. So this is how we think when you do treatment planning, and this is how you should think when you do your treatment plan. And then you decide the buccal segment relationship. So if we do a non-extraction treatment in the upper and lower, final molar relationship should be class 1. Extraction in the upper only, class 2. Extraction in the lower only, class 3. So just to summarize a little bit the process of treatment planning. So you start with planning the position of the incisors, as we mentioned, anteroposterior, vertical, and transverse. You ask yourself a question to achieve these treatment aims. Is the patient camouflageable? Can I do a camouflage treatment, or does he have to go for surgery? Do I need to do growth modification? If we're going to go now to the fixed appliance, then we knew the preferred incisor position, then we start with the lower arch, then the upper arch, as the criteria we mentioned about extraction and non-extraction. Which one is better, expansion or extraction, to correct the malocclusion in each arch individually? And then we hold the study model together and we look at the buccal segment relationship. We put the canine we start with the lower arch and see where the canine is going to end up in the lower arch. Are we going to move it forward or backward? And how much are we going to move this canine? Then we look at the upper canine relationship to the new position of the lower canine. And then see what are your molar relationship, and then consider do I need anchorage? Am I allowing these molars to move forward or not? Then you have to plan all of that. Once we are done with this planning, we move to the appliance design. So we know that we have either fixed, removable, or functional. And with the fixed appliance, now we have different prescription. The most common of them at the moment is MBT and Roth. So in this case, for example, am I going to go for Roth or MBT? So let's think. Your treatment aim is to procline, if we decided to go for a non-extraction treatment, is to procline these lower incisors. When you procline the lower incisors forward, you're going to go for tipping, but we don't want that. We need to have a controlled proclination. We don't want to excessively procline these incisors. So instead of going to a Roth prescription with a -1 torque in the lower incisors, I go for MBT prescription with a -6 torque, which means that it will kind of help me in avoiding excessive proclination of the lower incisors. And there's a huge examples and many examples on that, but this is only one example. It's not always possible to achieve the perfect aim of treatment. There is some limitation sometimes that either modify or change our treatment plan. The first one is the medical health. So if a patient, for example, has a medical compromised condition, bleeding disorder, we try not to go for the extraction option. Or if the dental health is compromised, for example, a badly or poor prognosis sixes, it's not possible to extract premolars and leave poor prognosis sixes, so sometimes that will affect your treatment decision. Age of the patient as well. Remember, if you have a growing patient and you are treating class 2, remember that the growth of the mandible continue, which is going to work with us. It's going to help us. This is the opposite if a patient is a class 3, because any growth will make it worse after that. And also the age is important because some patients who are old or like adult patients, they don't like long treatment. So sometimes they ask, okay, I don't care about my canine, I just need to straighten up my teeth. That's kind of an adult patient. And the patient compliance is very important. If patient with a good oral hygiene, you can go and achieve the ideal treatment aims, and you achieve them. Well, if the patient has a poor oral hygiene, he does not brush his teeth, or he keep breaking the bracket, then sometimes we have to terminate the treatment even if we did not achieve the full aims of the treatment. There's sometimes a limited factor related to the malocclusion itself. So the more severe the skeletal component of the malocclusion, the more it's the more we can't achieve the perfect and the ideal results of the treatment. So the more we have skeletal discrepancy, the less we can achieve the ideal or the aims of treatment. And to achieve the good fit that we are looking at, we have to make sure that there's no tooth size discrepancy as we measure it through Bolton discrepancy. So that's a good question, and saw it in the handbook for orthodontics. Andrew's 6 keys, realistic, goal, or impossible. Just remember when we do treatment planning that Andrews did his study in untreated patient. which sometimes is difficult for us when we are treating a severe malocclusion to get the same result that this patient has who did never done an orthodontic treatment. So it's not always, as I said, possible to do that. We try to do that most of the time, however. Thank you for listening.